Next, the cardiopulmonary bypass, the heart lung machine, in other words. So this is the heart lung machine. As you people could have seen this in your cardiothoracic theater in your general surgery posting. So this is the typical heart lung machine, right? So yeah. So what is the mechanism? What is the mechanism of the heart lung machine? I will show you. So as the name implies, it replaces the function of the heart and the lung. What is the function of the heart? Perfusion. What is the function of the lung? Oxygenation. So this machine maintains the perfusion and the oxygenation throughout the surgical procedure, right? So here, this is the SVC. This is the IVC. So venous return from both SVC and IVC will be drained to the venous reservoir, and that will be oxygenated with the membrane oxygenator, and the oxygenated blood will be returned back into the aorta, that is distal part of the ascending aorta, through the aortic cannulation. So this is the simple mechanism behind the usage of the heart lung machine. The deoxygenated blood collected from both the SVC and IVC will get oxygenated with the help of membrane oxygenator, and the same will be pumped into the ascending aorta. So that we used to apply the cross clamp here. So what happens? The blood won't enter the heart. The heart will be bloodless for the performing the cardiac surgeries, so that the blood will be moving into the arch vessels. So what are the arch vessels? This is the innominate vessel, left common carotid, left subclavian. So through these arch vessels, the whole body perfusion will be carried on. So this is the mechanism behind the heart lung machine. And what is the pump? What is the pump we are using in the heart lung machine? It is the roller pump, which we will be discussing. Yes, as I told, the principle of heart lung machine. The deoxygenated blood to CPB machine will be returned back safely to the body through the aortic cannulation, so that we can operate in a bloodless field. Next, coming to the arterial cannulation. So, which is the site for cannulation? As I told, it is a distal ascending aorta. Is a site for aortic cannulation after taking posting sutures. The cannulation site should be free of atheroma or calcified plaques. We should avoid dissection during cannulation. That is very important. What are all the alternate sites of cannulation apart from the descending, ascending aorta? Femoral artery and axillary artery. Axillary artery is somewhat antegrade route of blood flow only. Coming to the femoral artery cannulation, it will be called as retrograde, because blood flow is coming from the femoral artery in a retrograde fashion. So these are all the three commonest vessels we can use for cannulation of the arteries, that is aorta, femoral artery and axillary artery. So which method of cannulation is retrograde? Cannulation through the femoral artery is a retrograde method. So it is the picture showing the complete aortic and venous cannulation. So here you can see the aortic cannulation. Here you can see the venous cannulation. So how to cannulate ascending aorta in the following situations when it is inadvisable? Suppose the patient is having aortic dissection. It is impractical in some conditions. Suppose patient is planning for aortic root surgery, and in some conditions it may be impossible, like severe adhesions with the chest wall, or the patient is having a porcelain or calcified aorta. It will be very difficult to cannulate in those conditions. So how can we cannulate? So we can use, as I told, we can go for an axillary artery cannulation. We can go for a femoral artery cannulation. So conventionally, ascending aorta is the best site for cannulation. So the cannulation is not possible, like the aortic ascending aorta is full of filled with calcification, or the patient is having complete dissection of the entire ascending aorta. And if you are planning any arch procedures, so we can go for a peripheral cannulation like axillary or femoral artery cannulation. I remember femoral artery cannulation is a retrograde method of cannulation. Next, we are going to see about venous cannulation. As I told, the deoxygenated blood will have to be drained from the heart, so that in this picture, you people can see that here there is a single cannula, and here there is two cannulas. There are two cannulas. So This is called two-stage single venous cannulation. This method is called two-stage single venous cannulation because with the help of single cannula, both the IVC and the SVC blood will be drained with the help of fenestration in this cannula here. So that it is called as two-stage single venous cannulation. And this method is called as bicaval cannulation because SVC blood and the IVC blood will be drained separately by two separate cannulas. So this is called as bicaval cannulation. Again, this is a example of bicaval cannulation to drain the venous blood. So this is important. This is MCQ. So how the blood is drained from the heart? This is very important, and the effect is called as siphon effect or gravity, right? And we are not applying suction to drain the venous blood. The blood is draining from the right atrium into the reservoir with the help of siphon effect. It is also called as gravity effect. How to achieve this? We have to place reservoir 50 to 70 centimeters below the level of the heart. Again, it is very important for your MCQ. See, consider this is the table. This is the atrium. This is the venous cannula. The reservoir from the heart lung machine should be kept at 50 to 70 centimeters below the level of the heart. That is very important for efficient functioning of the siphon effect to drain the venous blood from the right atrium. Next, we can move on to the myocardial protection. And this is very important because we are going to arrest the heart. The ischemia starts. So how can we avoid ischemia and how can we protect the heart? This can be achieved by these three methods. We can deliver cardioplegia. So what is a cardioplegia? It is a potassium rich solution which will be used to arrest the heart during cardiac surgeries. And the next method is intermittent cross clamp fibrillation. It is the age old method. Before the invention of cardioplegia, they used to apply a cross clamp intermittently to fibrillate the heart so that in such conditions we'll try to decrease the myocardial oxygen consumption. It is one of the age old method, but we are not practicing regularly in these days. And the next method is total circulatory arrest with the help of deep hypothermia, right? Deep hypothermia. Even we can arrest the heart for a certain period of time. That will be discussed in our next slides to protect the myocardium and the whole body. So these are all the three methods which we are following for myocardial protection. So in general, the cardiac surgeries are done at moderate hypothermia. So what is moderate hypothermia? It is 28 to 32 degrees centigrade. And the very important point of MCQ point is the metabolic rate of all body organs is reduced by 50% with every 7-degree drop in temperature. This is very important. This has been asked in previous years. So that's why. So this is the mechanism behind hypothermia. So to reduce the oxygen consumption by myocardium, we are inducing hypothermia, and the metabolic rate is also decreasing by 50% with every 7-degree drop in temperature. So for total circulatory arrest, what should be the core body temperature? It should be cooled to 15 to 18 degrees centigrade. This is called a profound hypothermia. So with this hypothermia, even we can arrest the circulation. We are not going to run the heart lung machine even. So we are going to arrest the complete circulation to achieve a complete bloodless field. And the important point is with this complete total circulatory arrest with profound hypothermia, and the ischemia can be tolerated for up to 20 to 30 minutes. This MCQ, right? And apart from that, cerebral protection is very important. No, cerebral protection. This can be provided by placing ice packs around the head, and we can also use thiopentol. We can use steroids, right? And we can also use antegrade cerebral perfusion by using a separate carotid cannulation by maintaining a few ml of, say, 500 ml of blood per minute. Like that, we can maintain antegrade cerebral perfusion selectively in conditions where we are planning for deep hypothermia. So that and all at a higher level at your stage. So for MCQ point of view, you should learn for to achieve a circulatory arrest, we can reduce the temperature. We can go up to 15 to 18 degrees centigrade, and with this temperature, the patient can tolerate up to 20 to 30 minutes of circulatory arrest. Next, what are the different methods of cardioplegia? So, how can we instill cardioplegia? By what route? The first and foremost commonly used method of cardioplegia is aortic root cardioplegia, and the next method is intracoronary infusion of cardioplegic solution. Intracoronary infusion. I will be showing you with the diagrams. Then the next method is infusion of cardioplegia through the coronary sinus. So among these methods, the commonest method of instilling cardioplegia is aortic root cardioplegia. Why? Because the coronary osteums arise from the aortic root, and few procedures where we need to open the aortic root in conditions where we are going to do AVR for an aortic regurgitation. So in those cases, the aortic root pressure may not be good enough to give cardioplegia through the coronary ostium, because there will be a patient is be having aortic valve incompetence. So in those conditions, we couldn't able to deliver cardioplegia at the aortic root. In those conditions, we can go with coronary ostial cardioplegia. We'll be having a few diagrams for your easy understanding. This is the instilling cardioplegia through the aortic root. See, in this diagram, you can see nicely the aortic cross clamp has been applied, and the aortic root, we are taking a separate bursting suture, and through this suture, we are infusing cardioplegia. This method is called as aortic root cardioplegia. And can you able to see this? We are incising the aortic root to visualize the coronary ostium, right? Through the incision, we are opening the aortic root, and after opening, we can identify both the coronary ostiums. This is the right coronary ostium, which will be in the anterior aspect. This is the left coronary ostium, which will be in the posterior aspect. So by directly opening the aortic root, we can visualize the ostium. We are giving cardioplegia through the ostium. So this is these two methods, that is aortic root and coronary ostial cardioplegia method, or antegrade method of cardioplegia. Right, another diagram showing coronary ostial cardioplegia delivery, and the installation of cardioplegia through the coronary sinus. Through the coronary sinus. So where is the coronary sinus? It is in the right atrium. It is one of the greatest vein in the heart. So delivering cardioplegia via the coronary sinus is a method, is an example of a retrograde cardioplegia, right? So with the help of TE guidance, we can guide the retrograde CP catheter into the coronary sinus to give cardioplegia. So we have seen three methods of giving cardioplegia. The two are antegrade method, that is aortic root and aortic ostial cardioplegia method, and the third one is a retrograde method, that is via the coronary sinus. Next, we can move on to the most important point. Before the start of the heart lung machine, we should give heparin. So what is the dose of heparin that to be given before the start of the heart lung machine? So that's the question. How much heparin is needed before aortic and venous cannulation? The options given are 100 units, 200, 300, 400. So among this, you have to think. Yes, the answer is 300 units per kg, or in other words, 3 milligram per kg. So that is very, very important. Why that is important? To avoid the coagulation cascade. So heparin is very, very important before the start of heart lung machine. So the dose is very important. We are using 3 milligram per kg or 300 units per kg. That is very important. We have to achieve an ACT. After giving heparin, we have to wait for 3 minutes and we have to check for ACT. Matches our more than 480 seconds mark, we can start the heart lung machine. So achieving an ACT of more than 480 seconds is very, very important. So after completion of the whole procedure, we need to reverse the heparin with protamine. At what ratio? This is very important. We have to reverse protamine with heparin in the ratio of 1:1.3 to achieve a good hemostasis after the procedure. The next question, which of the following pump in cardiopulmonary bypass machine is associated with hemolysis? The roller pump, centrifugal pump, centripetal pump, infusion pump. In the previous picture, you people have seen that in the heart lung machine, there is a pump which will be used to pump the blood into the aorta. So, what is the nature of the pump in the conventional heart lung machine? That too cause another side effect, the hemolysis, if we use that for a prolonged period of time. That is the roller pump. So conventional CPV machine, we are using the roller pump. One of the main drawback is hemolysis if we use for a period of more than 7 or 8 hours. So roller pump, there is higher rates of hemolysis. So what is centrifugal pump? Roller pump we are using in conventional cardioplegia, having a drawback of hemolysis. In ECMO, ECMO is nothing but a miniature of the heart lung machine. In ECMO, we are using a centrifugal pump where the hemolysis rate is 0. Next, we can move on to this question. What is the incidence of stroke after the use of the cardiopulmonary bypass? It is given in the new edition books. The incidence of stroke is 1.5%. It is given in Sabiston, in the new Sabiston, right? Always the inflammatory mediators will be triggered with the use of the artificial circuits in the heart lung machine. So always there is a probability of stroke. How that can be minimized? We can minimize that by maintaining the adequate cerebral perfusion in the heart lung machine, and we can also minimize the fat embolism. So since we open the pericardium, there may be definitely fat deposits from the myocardial fat and all. It could be mixed with the blood. So we can try to avoid putting the continuous suction over the field. In that way, we can minimize, and we can also minimize the aortic manipulation while putting the clamp and all. We should assess the aorta which is free of that plugs, and we have to apply clamp at a single stroke. If we make 2 or 3 strokes of aortic clamping, even that may trigger the possibility of embolism, and we can institute a moderate hypothermia. That is very important for cerebral protection, right? These are all the methods to minimize the stroke in the heart lung machine. And that is very important. Ischemic time, because the permanent myocardial damage can develop within 15 to 20 minutes of a circulatory arrest. So for that, we are giving cardioplegia, and we are using moderate hypothermia to decrease the metabolism and decrease myocardial consumption and to mainly protect the heart. So our conventional cardioplegia, what is the main thing to use to arrest the heart? It is potassium. Potassium arrests the heart in diastole. It depolarizes the myocyte, right? And the important thing is arrest the heart in diastole, the potassium. This use of CPB, maybe it be having very beneficial during cardiac surgeries, but it is with complications. So that can be avoidable, but there are complications. What are the complications with the heart lung machine? Bleeding disorders, since we are using protamine and heparin, there is a possibility of bleeding disorders. And not only with that, the inflammatory cascade may get triggered with the use of the heart lung machine. The probability of infection is there, the air embolism will be there, and because of embolism, there is a possibility of intestinal ischemia or cerebral ischemia, and myocardial depression because of the triggering of the inflammation. Then the post cardiotomy syndrome is a possibility. It is nothing but the restless like syndrome, as the patient will be having raised count and WBC count. The patient may complain of fever because of pericarditis after cardiac surgery. And there is also the possibility of pulmonary injury in the form of pump lung syndrome, again due to the activation of inflammation. So such problems can be maximally minimized by giving adequate heparin, by giving steroids conventionally before the start of a heart lung machine, and in some centers they routinely use mannitol, right? Next, total circulatory arrest. Again, we are going to review this. It is of deep hypothermia by keeping around 18 degrees centigrade. And the important point of is the metabolic rate is very important. It is reduced by 50 percentage, right? With every second degree or a 10-degree drop in temperature. A few books are giving some values. So always you should know the hypothermia will reduce the myocardial oxygen demand and the metabolic rate. That is very important. And using this technique, we can carry out circulatory arrest for about 30 to 45 minutes. Yes. What is the safer period of deep hypothermic circulatory arrest? As we have discussed elaborately about the circulatory arrest, you people can definitely answer this. The answer is about 30 minutes. It is given in Bailey. For total circulatory arrest, the core body temperature should be around. So we have seen in our discussion, it should be around 18 degrees centigrade. So using this technique, we can carry out the procedure for even up to 30 to 45 minutes. By if we do a safely means, we can go up to 30 minutes. Yes, next question is methods of myocardial protection during cardiac surgery includes the cardioplegia infusion into the coronaries, intermittent cardiac fibrillation, profound hypothermic circulatory arrest, all of the above. So we have discussed the answer is all of the above. The next question, which contains the most deoxygenated blood in the body? In the right atrium will be having the deoxygenated blood. The right atrium receives blood from SVC, IVC, and the coronary sinus. So among this, which contains the most deoxygenated blood in the body? The pulmonary vein will be ruled out as it carries the oxygenated blood from the lungs. So among the options, it is the coronary sinus because the heart is contracting throughout the lifetime, right? So heart consumes the most number of oxygen when compared to all other organs. The coronary sinus is one of the greatest vein that empties into the right atrium, empties into the right atrium. Even though SVC and IVC are draining into the right atrium, the most deoxygenated blood will be from the coronary sinus. And this question you people can answer. The potential complications of CPB are all except bleeding disorders, air embolism, myocardial depression, all of the above. And kindly, don't omit this except. The question is the potential complications of CPB are this is all of the above. So all of the above are complications of CPB as we discussed in the previous slides. And the neurological problems are more common. It is about 1.5 to 2%. I have explained, and bleeding due to platelet damage, and also we are using more number of heparin and protamine. The whole body inflammatory response will get triggered. That is very important. So that may cause a pump lung syndrome, and that may induce the post-op ventilation in some more patients because such kind of inflammatory lung will need takes time to recover. Then renal failure, again because of the same mechanism. A cardiogenic shock or failure to wean will be a factor. Some patients may need a permanent pacemaker. The respiratory failure may also be there, and very few individuals may end up in cardiomyopathy. So these are all the complications of the heart-lung machine. And in New Bailey, it has been given and this table. What are all the alternate uses of CPB? So whenever new points has been added, you people has to pay attention to that. Alternate use of CPB are we can use for rewarming. When the patient went for hypothermia by some other condition, we can put the patient on CPB and we can make the patient to rewarm from hypothermia. And in case of severe respiratory failure also, it will be used as a resuscitation in a patient with severe respiratory failure and as an adjunct in pulmonary embolectomy. So during the procedures pulmonary endarterectomy, then pulmonary embolectomy and all, the use of heart-lung machine will be very, very helpful, right, in those conditions because that oxygenation will be well maintained with the help of the heart-lung machine. Then during a single and double lung transplantation will be very useful. In major cardiopulmonary trauma, the blood loss will be more. In those conditions, we can put the patient on heart-lung machine to minimize the blood loss. And certain non-cardiac surgical procedures, MCQ, right? a resection of very vascular tumors, those invading larger blood vessels. In those conditions, we can start the heart lung machine. Suppose the tumor seems infiltrated into the IVC, means we can go for circulatory arrest. We can easily remove the tumor, and then we can restart the heart lung machine. So these are all the new topics given in the Bailey. So kindly concentrate in this table.